Welcome everyone to our program today focused on Waldenström's macroglobulinemia and mental health support. A quick introduction, my name is Stephanie Trong. I'm the founder of The Patient Story after my own non-Hodgkin lymphoma diagnosis a few years ago. Now the goal of our platform is to help patients, care partners, anyone in the support circle navigate that life after a diagnosis. What does this mean? And in human terms, not in the medical jargon and all the outdated statistics that we're often inundated with. So the Patient Story primarily does this through in-depth patient stories and educational programs like today's. And I don't have to tell you, it's especially important in a space like this, Waldenström's, where patients and families are told many times right at diagnosis that there will be no immediate treatment and that you'll enter a period known by most as watch and wait, or wait and worry. Today is all about support in getting through something as difficult or maybe as jarring as hearing that. So before we get to our discussion, we want to thank the Leukemia and Lymphoma Society for its support and creation of this independent educational program, which helps us host more of these and for free always for our audience. For those unfamiliar with the LLS's work, quick summary here, it has invested over $1.5 billion in blood cancer research and provides free educational resources and support like the information specialists on hand who provide one-to-one support on everything from questions about treatment to social and financial challenges. Thanks also to our promotional partners, the International Waldenström's Macroglobulinemia Foundation, or IWMF, which provides also free resources specifically to the Waldenström's community, from wellness resources to peer-to-peer support. Now, while we hope you walk away with more knowledge, this discussion is not meant to be a medical advice substitute. Please speak with your own medical team about important decisions. And one last housekeeping, our survey. We really want to hear your feedback, and it is incredibly important because the way you feel about how things went today, or how the stories and programs resonate or don't resonate with you, we take to heart. So the survey will pop up after this discussion closes, and it'll just take a few minutes and we'll really appreciate it. Okay, now on to the great stuff today. Really lucky to know this man who's going to help lead our conversation today, Pete DeNardis, who not only has been an incredible part of the IWMF, but himself, as someone who was diagnosed with Waldenström's many years ago, became an advocate, and we were able to feature his story on The Patient Story as well. And so, Pete, I want to thank you for taking the time to do this, and we'll send it over to you now.
Thank you, Stephanie. I'm Pete DeNardis. I'm a WM patient myself. I was diagnosed in 2003 at the age of 43. And I've been a volunteer for the IWMF since 2005 and been a board member for a long period of time, currently serving as the chair of the board of trustees. I've had WN since 2003, as I stated, and I've been in multiple periods of treatment and watch and wait. So I understand personally the impact that Waldenström's has on you when you're navigating through those various periods, both physically and mentally. And I look forward to our discussion today with our two esteemed doctors. We have, first off, I'd like to introduce Dr. Jonas Paludo. He's a hematologist oncologist at Mayo Clinic and has been there for 12 years. He's part of their lymphoma group, and that includes Waldenström's macroglobulinemia. And he also investigates the effectiveness of various treatments for WM and examines the outcomes of patients with the disease and has studied the genetic mechanisms associated with the development of this malignancy. Can you share with our patient and care partner audience, at what age did you know you wanted to be in medicine and what drew you to becoming a doctor?
Thank you for the kind introduction, Pete. I think my story is honest. I always thought I was going to be an electric engineer. I enjoyed math and physics, and I had the opportunity to experience firsthand kind of the difference that a good doctor can make in the life of patients and families when they go through a cancer diagnosis when I was late in high school. So I thought that was my calling to be able to help patients and people when they are struggling with difficult disease and diagnosis. And I changed my mind at the very last minute and applied to medical school and never looked back.
Thank you. Interesting. I too wanted to be an engineer initially, but the math and physics, I have to admit, were a bit much for me. So I'm glad that you stuck with medicine, though. We all are. And I'd like to also introduce Dr. Sarosiek. She's a hematologist, Shayna Sarosiek. She's a hematologist oncologist at Dana-Farber Cancer Institute, and specifically at their Bing Center for Waldenström's, which is the largest center in the world dedicated to the study of and development of new targeted therapies for Waldenström's. She's involved in clinical research focused on the use of immunotherapies and antibody treatments, and she also sees patients on a day-to-day basis and deals with patients who have both WM and amyloidosis. So Dr. Sarosiek, I'd like to ask you the same question. What age did you know you wanted to be in medicine, and what drew you to becoming a doctor?
Thank you so much, Pete, for the kind introduction. To answer your question, I would say I don't know exactly how old I was, but I was very young when I decided I wanted to be a doctor. I was really interested in biology, and I was what some people would call somewhat nerdy. I had, instead of pictures of bands on the wall in my room, I actually had a poster of every system in the body, the circulatory system, the musculoskeletal system. I just had anatomical, setups with skeletons and things like that around my room so that I could study the human body. So I've known for a very long time and had a close family member with cancer when I was a child, and that's what drew me to cancer care specifically. But I've known for a long time, and I'm very happy that I'm in this field.
You are too. Thank you. That's interesting. I don't think all my childhood friends, I don't think I ran into anyone that had those kind of posters on their walls. So.
Yeah. I was alone too. My friends also didn't have the same things, but I enjoyed it.
Good. Okay, so now we can kind of move on to the initial part of this discussion and kind of talk a little bit about the understanding of what WM is. So first for Dr. Paludo, can you describe Waldenström's macroglobulinemia?
So Waldenström's is a type of lymphoma. There are many different types of lymphomas, several dozen to be honest, and they have different ways that how they behave. They come from different cell types and different classifications. Waldenström's belongs to what you call non-Hodgkin's lymphoma category, which has several dozen different lymphoma subtypes. Waldenström's is also sometimes called the lymphoplasmacytic lymphoma, as the usual lymphoma, as the lymphoma involving the bone marrow of the patients. This type of cancer comes from what they call B cells or B lymphocytes. They're part of our immune system. And for reasons that we don't understand exactly why or how, when one of those normal B cells or B lymphocytes becomes a cancer cell, starts to grow and starts to take up space in the bone marrow. But it does grow very slowly. And that's why we also classify Waldenström's as we call indolent lymphoma. That is just medical lingo to say it's a slow-growing lymphoma. It's an indolent lymphoma that comes from B cells and belongs to the category of non-Hodgkin's lymphoma. But Waldenström's is very unique in a way that it not only have the cancer cell in the bone marrow. Those cancer cells can go to other organs, of course, the lymph nodes, the spleen. But the uniqueness is that it produces a protein called the IgM protein that can circulate in the blood. It can cause different types of symptoms along the way. So,
thank you. And now for Dr. Sarosiek, sort of a follow-up to that. What's the most common way? We know that WM is rare, as Dr. Paludo just mentioned, but what are common ways that people find out that they have Waldenström's, and what are the symptoms when they're diagnosed?
So if patients find out in a multitude of different ways that they have Waldenström's. A lot of patients don't have any symptoms, and this is picked up incidentally. So it's just picked up when they're having other testing done. I would say one of the most common things I see in my clinic is that on routine blood tests, just with the normal primary care follow-up, that patients are noted to have a high total protein. So the IgM antibody that you heard about from Dr. Paludo that's made in Waldenström's that's a type of protein. And so often a protein level in a patient's blood might be high if they're making a lot of IgM. And so that's one way. I have some patients that it's picked up because they had an MRI for other reasons, maybe back pain or something like that, and the bone marrow looks active or looks like it has some changes on an MRI. So, and then some patients are noted to have anemia on routine labs. Even if they don't have symptoms from it, their doctor notices that their hemoglobin, or the level of red blood cells they have, is a little below normal. And so sometimes it's picked up just incidentally with other testing. And sometimes patients do have symptoms. The most common symptoms we see with Waldenström's, both at the time of diagnosis and time of treatment, are symptoms of anemia. So some patients present to their doctor because they notice that they're feeling tired or weak, or they get short of breath with their usual activities. And probably one of the more common things I hear in my clinic is that patients say, oh, I'm getting older, so I just thought I'm running slower because I'm getting older. And in reality, it's because they've developed some anemia and their disease has progressed. So any of those symptoms of anemia might happen. It might be a cause for patients to present for a workup. And then occasionally, this isn't as common, but sometimes patients present because they have symptoms of hyperviscosity or thickened blood. So they might be having frequent nosebleeds, might be something that's happening, or even visual changes, and their eye doctor notices some bleeding in the blood vessels in the back of the eye. And so sometimes they might have symptoms from thickened blood, but it can be a variety of different things that happen and lead to the diagnosis.
Thank you. Yeah, I can kind of attest to that, as my diagnosis came as a result of a blood test I had for another reason, and the doctor just said, hey, you have elevated protein levels. And initially I just thought, well, I'll cut back on my red meat and that'll lower the protein level. I didn't know anything about it. But yeah, that is a common thing I hear from other patients also, that their diagnosis comes through that route. So I want to kind of move on to start talking a little bit about the watch and wait process and active surveillance. As I stated, I've had Waldenström's for almost 20 years now, so that watch and wait definition has kind of evolved for me and continues to evolve depending on the stage of the disease that I'm at. So initially it was to watch and see how well the treatments were working. But in between treatment periods, that watch and wait does turn into more of a wait period process. But each time there's a blood test, you have a little bit of anxiety as to what the results will be. And I kind of learned over the years to watch the trends and not focus so much on one blip up or down. And that's kind of helped me relax a little bit in the process. It's not easy, and it can be can lead to a lot of anxiety on the part of the patient and the caregiver. But it is important to watch those trends and also stay in close contact with your doctor. So can you describe, like, from your perspective, the watch and wait process?
Watch and wait, the watch and wait process, or time, as a short answer, is that time between diagnosis or treatment until the time when we have to do something about the Waldenström's or start treatment. That's the time when you're just kind of monitoring the disease. So we're just waiting for symptoms or waiting for changes that would require treatment. Now, as you mentioned, Pete, you were diagnosed when you found an abnormal protein in the blood. So I'm assuming you're not having any symptoms at that time, and that's the case for a good proportion of patients diagnosed with Waldenström's. As Dr. Sarosiek mentioned, you just found an abnormal test. You had a test done for some reason, and it's abnormal, and then that leads to another test, and here it is, this Waldenström's diagnosis, but you're feeling well, you have no symptoms at that time. And because Waldenström's is a very slow-changing, slow-growing disease, we know that a lot of patients can go for many, many years without having any trouble, any symptoms from this disease. So the watch and wait approach, or the watch and wait time, is that time from finding about the Waldenström's from diagnosis until the time when you have to do something about it. Okay, and maybe we can talk more about that later, is when and why we have to do something about it. But watch and wait is a period where we are monitoring, keeping an eye on things, monitoring the labs, the trends of the protein, hemoglobin, platelet count, symptoms. So some people call it active monitoring because we are doing the routine, frequent follow-ups with labs, doctor visits, looking for symptoms, looking for changes that would suggest that treatment or something about the Waldenström has to be done. So that's kind of an overview of what the watch and wait time is. If Dr. Sarosiek, I can want to add, what are any more thoughts on that?
Yeah, I agree with everything you said. And I think that, generally, I would say from my perspective, the process of watch and wait or active surveillance or active monitoring is really keeping an eye on a few key things. One, I think most importantly is patient symptoms, because often the symptoms will align with the patient's lab results or physical exam, but sometimes it doesn't. And most importantly, we're really trying to maintain a patient's quality of life. So during that period of watch and wait, we're monitoring patient symptoms. We're monitoring blood work because, as you heard, we need to, if there are changes that can become concerning for a patient or could become dangerous or are significantly different on the lab work, then that's the other thing we want to watch. And then the physical exam. Sometimes patients develop lymph nodes that are enlarged or bothersome to them, or an enlarged spleen. And so I think the labs, the exam, and the symptoms are really kind of the key things we're keeping an eye on during that watch and wait period. And I would say, I think, Pete, you really hit the nail on the head with saying that watching the trend is really important, because in any of those things, the exam, the labs, or the symptoms, there can be some natural fluctuation. So in the lab results, maybe sometimes the IgM might bump up a little bit, or it could go down a little, or, if a patient, let's say, had a viral infection, it could affect the lab values or something like that. So really, it's more about the trend over the course of time rather than one lab value. And the same thing is true for symptoms. If a patient is sick, then they might feel more fatigued one week and things could get better the next week. So we really do like to see the trend of how all of those things are going over the course of time during the watch and wait period.
Thank you. Yes, back in the day, so it shows how long I've had Waldenström's. I used to keep a spreadsheet where I track the trends. I don't have to do that anymore, thank goodness, due to the pace of the technology advancements. You can now go onto a portal and see all of that. But my doctor used to expect that and wait for me to hand him the sheet that I put together, and so we could look at the trends together. Dr. Sarosiek, and you can answer this too, Dr. Paludo, but is there a standard when someone is in watch and wait, let's say, and the prior treatment worked and we're just waiting to keep an eye on them? Is there a standard period of time that you do blood tests? Is it, every month, 2 months, 3 months, or does it vary?
It does certainly vary from patient to patient. I would say on average, probably for most of my patients, we end up on every 3-month follow-up. A lot of patients have very slow progression of disease, and so we want to keep an eye on it. But it really depends on the patient, because sometimes we have patients that have been stable for years, and so we might extend that follow-up to be, every 6 months or something different, to align with what we know is happening with their disease. And honestly, I think as what we mentioned, and what we'll talk about more in terms of mental health for patients is sometimes, especially at the beginning, when patients are beginning to adjust to their new diagnosis and learn more about the disease and probably have more questions. And I think more frequent follow-up actually sometimes happens, just even if we don't feel like we need it from a lab perspective. I think to allow patients to ask questions and get used to having this disease, sometimes more frequent follow-up we do just to check in with patients, because it can be important from a mental health perspective. I don't want any of my patients to be at home, thinking they wanted to check at 2 months and spending the last month of the 3-month wait period just waiting and being totally anxious at home. So sometimes we'll check in a little more frequently, especially around the time of a new diagnosis. But I would say on average, probably 3 months. I don't know, Dr. Paludo, if you have a similar experience or not.
So just to complement that, we have a very similar schedule. We tend to follow up with patients on the watch and wait approximately every 3 months, especially at the beginning, as we have a better idea of how the disease is changing and what the trends look initially, and then assuming that everything is stable, things are mostly stable, then we start to space those visits to about every 6 months, sometimes even a little longer, depending on the patient, what they might be experiencing, where they're coming from, and things like that. But I would say usually every 3 to 6 months, we're having some clinic visits, we do some labs, so we can monitor the trends.
Thank you. Yes, and I think both of you kind of touched on it, but with regards to the frequency of testing, Dr. Sarosiek hit on something that I hadn't considered, the mental aspect behind the timing. And you're not just focused on the physical aspects of what the patient is going through, but also mentally. And I hadn't considered that. And, looking back, I think, oh, yeah, I guess that did happen for me also. So I really appreciate that. That's part of, I guess, the art of being a doctor, and it's not just science. So I compliment both of you on your ability to do that. And I've heard from a lot of patients that say you're both fantastic. So you're obviously doing something right and doing it the right way. So what I'd like to do now is, since this kind of leads us into the next part of the discussion, which is those mental health issues surrounding being on watch and wait. So as I mentioned before, personally, I've been in various stages of various phases of watch and wait based on where my treatment has been. So I've been through multiple rounds of treatment. And in between, of course, is that watch and wait period. But fortunately, I have a strong support network with my family, my wife, my kids, my cousins, and things like that. So I have people that can support me. Not every patient has that, and I understand that. I've talked to a lot of patients through my involvement with the IWMF who don't have that. And I also am involved with the IWMF, and patient support is important. And talking to other patients helps also in that regard, and being part of a support group. So, all that being said, there are still periods where you have rough patches where you don't know what's going to happen next, and you're either anxious about where your disease is heading or when the other shoe's going to drop, or even when you're in a period of treatment. I know we're talking about watch and wait, but a period of treatment where things aren't going as you're not getting better as quickly as you wanted to, and you get depressed. It's important, and I know both of you will probably touch on this also, but it's important to take advantage of your support network, talk to your doctors, seek mental help if you need it. There's no shame in seeking mental help at all. In fact, you're to be commended for doing so, because you're taking active control of your disease and of your condition. For the doctors, I guess for each of you, what are most common questions and concerns you get from your patients when it comes to watch and wait? And what are the top tips you provide them when they're going through that process? Dr. Sarosiek, we'll let you start off.
Sure. I think, one thing I'll touch on is just, I feel like, mentally for a patient who has cancer, something changes in terms of the way that you think about new symptoms that come up with your body. If you don't have cancer or haven't had a major medical issue and you have a little bit of back pain, you might think, oh, maybe I hurt my back, and just move on with your day. But then once you have this underlying cancer diagnosis, I think you start to interpret symptoms in a different way. And I see that very commonly, and it's very normal for that to happen with our patients with Waldenström's and other cancers, that then you start to see your symptoms through a new eye. And I think I hear that frequently from patients. And from my perspective, I think it's really important to have an open line of communication with your provider to relieve your anxiety about those things, especially at the beginning when you don't know exactly what to expect from your Waldenström's or what symptoms you might have. So, I have many patients that will just reach out and they say, I know this probably isn't related, but I just want to reassure myself. I have this new pain, or I have this new symptom. Do you think it's part of the Waldenström's, or do you think it's something bigger to worry about? And I think that's a really important part of the active monitoring and surveillance, is just being able to have that open line of communication to ask questions about those small things which otherwise you might have ignored, but now you don't know really how to put it into the context of your Waldenström. So that I think is important to keep in mind, to not be afraid to ask, just to, allay your anxieties and be able to really just enjoy your quality of life without having to worry every day about the small things.
Yes, and I completely agree. I think that's a very common question we're getting from patients as they're worried about their symptoms and new symptoms. I'd say another common question that I get usually at the beginning, usually at the first time we were talking about watch and wait, is a concern about sometimes not doing anything about the Waldenström's or the lymphoma, right? You just told me that I have Waldenström's, now you're telling me we're not going to do anything about it. So that's a common question, and I try to kind of go over and I discuss the rationale for that, the quality of life component, and reinforce that we're not doing anything. It's not like we're not just forgetting about it. We're just going to have that frequent, regular time points to check and to monitor for things, but also Sarosiek mentioned, have that open line of communication, and I'll tell the patients, ask questions. If you have any concerns, to contact us so we can discuss, because it does create a great deal of anxiety, especially at the beginning, especially as patients are getting used to live with Waldenström's, about saying, no, you have a disease and we're just going to not give treatment or start treatment right away.
Yeah, and I think in that, just to follow up on that, I think in that setting, as you mentioned, Pete, it's important to really find the support and resources that work best for you. As you mentioned, a lot of people have their families and friends to be support. Some patients don't have that, and they might find their support in other places. A lot of institutions have great social work care or psychosocial teams that can help deal with the anxieties and mental health issues surrounding a diagnosis of cancer. But there are a lot of resources like the IWMF, and patients, I think, should feel free to really utilize those in any way that they want. Some patients really benefit from talking with other patients and being, an active participant on the forums. Other patients maybe at the beginning might find that overwhelming and don't want to, necessarily get all of that information and might want to learn on their own through the patient-directed, education or things like that. And I feel like patients should really just feel free to use the resources available to them and find the support in ways that they find most helpful. They don't need to feel like they have to use everything that's available or use specific resources. But really, I think it's about just finding a balance of what is most comfortable in their own support system, but also with their physician in terms of follow-up and communication.
Thank you to both of you. Those are very insightful responses, and hopefully people will find some help and guidance in that. Personally, like I've been on this journey for a long time, and I'm at a point where my disease is behaving itself, and it's been doing that for a while. So now I'm at the point where, believe it or not, I'm worried more about my children and my grandchildren. So if they have a bruise or some strange thing, I think, well, could it be Waldenström's or something related to that? So a different level of anxiety. And I hate to admit that, but it's true. With terms of different patient profiles like age, gender, where they live, and other considerations, does that impact how you approach or how you work with the patients on that watch and wait process? Does it matter, where they are in terms of what type of patient they are, age-wise or gender-wise, or even whether they're urban or rural or anything along those lines?
That's certainly influence to a certain degree, the watch and wait, especially at the beginning. Of course, I'm always thinking about how can Waldenström's and maybe other medical problems that patients may have, interact. Am I concerned about, for example, a potential kidney problem in that specific patient because they may already have other risk factors for kidney problems, or am I concerned about something else or a big spleen? So depending on how the patient is presenting, depending on what maybe other medical problems they may have that could interfere with Waldenström's, I may look at that and adjust a little bit the watch and wait. At the end of the day, it's all about the trends and how the patient is feeling and their labs, but depending on other medical diseases or the problems, we may kind of keep a closer eye or adjust the watch and wait period. So those are the main things that I look at, what patient characteristics for that.
Also, you mentioned, urban versus rural in terms of where a patient resides. I think that also can impact in terms of their watch and wait and maybe their continued care. Dr. Paludo and I are both very fortunate to work at larger academic centers where we get to have more experience with specific diseases. And I think that, in terms of watch and wait, sometimes it is helpful if patients, if they're a local doctor, if they're in a rural area where they might not see as much Waldenström's, I think, accessing that additional educational information, or even if they are able to connect with someone at a larger academic center, I think that can be helpful in terms of continuing to follow the disease. So, that affects, from my perspective, I work a lot with local oncologists in terms of developing watch and wait plans and seeing what they're comfortable with, what the patient is comfortable with. So it's more in some settings, not just me with the patient, but also me with a patient and a local oncologist in terms of developing a plan for active monitoring.
Thank you. So if either of you have had a patient who's going through a mentally difficult time, do you do anything different in the treatment plan, or do you discuss different types of things with that patient? How do you work through that process when they're on watch and wait and they're particularly anxious?
That is always a component of our discussions and our visits. Talk about the stressors, the anxiety symptoms as well. So depending on patients that they may have a little bit more of a higher anxiety level during that moment, which is not uncommon, to be honest. I often tend to meet more often with that patients. I may have shorter intervals between appointments, so we can monitor labs a little closer. I found that usually helps a lot with those patients. But more important than that, we have fortunate to have a very large group of psychologists, psychiatrists at Mayo that are expert in patients with cancer. So I tend to make a referral earlier in the disease process. So I tend to connect my patients with that group early, so that they can have that connection. They have other professionals to speak with and to talk to, other than, of course, share the different resources available outside of our institution.
I think that's part of the beauty of Waldenström's in general, since our patients do really well and we get to know them very well. I think, we are hopefully able to just have these open conversations with patients about when they're, feeling more anxious or would like to be connected with more support systems, or even just be able to know based on our general conversations during the visit if there's anxiety about specific things happening with the disease, and we can connect them to resources or see patients more often. I have many patients that from a medical perspective, I would feel comfortable seeing them less often, but the mental health perspective of this is also very important. So I continue to follow a little bit more closely to be able to manage that part. So I think, keeping both the mental and the physical health in mind is a really important part of the follow-up.
I also happen to be I'm a patient, but I also kind of happen to be a caregiver. My wife has a related blood cancer, and it's kind of strange then to find myself wearing the caregiver hat. So do you ever deal with or work with caregivers in this regard? Do you have advice for them specifically when you're going through the watch and wait period?
Yeah, certainly. That's a great point to bring up, because I do feel like caregivers carry a big portion of the, burden of the disease for sure. And I think often we have a great social work team, and often the social work team is quite wonderful in terms of working with the families and seeing what needs the caregiver or the family member might have. And so that, I think, from my perspective, has been really helpful. But I also just think it's important to, when a patient brings someone to an appointment, I think it's really important to, I always try to address if the family member or caregiver has other questions too, because you're right, they really, are quite involved and often are the extra set of ears to help be able to relay, to be able to, manage or quell the anxieties that the patient has later, if they are that extra set of ears that can later, report back information that might have been too overwhelming at the time of an initial appointment or something. So I always think that's a key part of caring for the patient during the visit, is whoever they bring along is clearly someone that is important and involved in their care and making sure their questions are answered too.
Yeah, caregivers are very important, especially in Waldenström's as well. So I think, including them and checking with them as well, because they might be experiencing different levels or different types of anxieties and concerns. And then the patients, sometimes I feel like the caregivers are also looking for other things that we may often don't discuss very often or very much in the visits. They're also concerned about, family, work-related, financial component, things like that are important topics that sometimes are not in the center stage of the discussions, but are important to address. And they do provide a lot of support to the patients. So it's important to make sure they are supported. The caregivers are supported as well.
Yes, I know for myself, having to wear that caregiver hat, I had a newfound respect for what my wife had been through for years and years and years. It's in many respects harder than being the patient, and I have a lot of appreciation for all the caregivers out there, and of course for the physicians that are working with us and trying to help us in these difficult time periods, whether we're in treatment or in a watch and wait process. At this point, we kind of want to touch on maybe some current treatment landscape or what the treatment is like for Waldenström's patients and possibly where we might be headed. I know myself, when I was first diagnosed 20 years ago, Rituxan was a fairly new treatment paradigm. And there were concerns about, is this safe to take over the long haul? Of course, we know much better now, but back then we weren't sure. And so my initial treatment is something that isn't used anymore. It was fludarabine, Cytoxan, Rituxan, so it was heavy duty stuff. And, I've had other treatments over the years. I have an unusual disease course. So I've had, 3-4 different courses of treatment. And I'm currently on a BTK inhibitor, which is working well for me. And I'm, because I have a different manifestation of the disease. So I'm a little bit different, but I also get monthly IVIG, which is primarily because the treatment works so well that my immunoglobulins are gone. So I do need a monthly infusion because of infections, really, monthly infusion of IVIG. But that's me. I'm a patient of one. Every patient is different. So in terms of, and just having a discussion with a patient recently of, is this the right treatment path for me? I said, well, it depends. So what are the standard treatment options for patients currently? Like if they're newly diagnosed, what do they have to look forward to in terms of options?
Luckily we have many different options, which is wonderful. So over the course of time, if a patient's disease is, progressing or comes back, we have a lot of different treatment options. I would say most commonly for a patient that's treatment naive, so they've never had any treatment for their Waldenström's, we think of two big categories for first line therapy. So we often think about BTK inhibitors, like you mentioned. There's zanubrutinib, which is probably more commonly used now, but also ibrutinib or acalabrutinib. So that's an oral tablet. And then there's chemotherapy, as you mentioned, with rituximab. So there are quite a few different chemotherapies. Fludarabine is one of the older ones we don't use as frequently anymore that you mentioned. Bendamustine is often what we use in the United States with rituximab, but there's also another chemo called Cytoxan or cyclophosphamide that can be combined with rituximab. So I would say those are probably the two most common things: rituximab with a chemotherapy or a BTK inhibitor, the oral tablets. There is another class of drugs called proteasome inhibitors, so something called bortezomib or a related drug that we can also use. I tend to use those in younger patients, and a lot of patients with Waldenström's have neuropathy, and so we don't use those drugs as frequently because neuropathy can happen with that group of drugs. But those are the chemotherapy and the BTK inhibitor, probably for patients who haven't been treated before, are most frequently used. But there are other options too. There are other oral therapies like venetoclax or the newer BTK inhibitor, pirtobrutinib. So there are different options available as well for patients who have had their disease come back. And as always, we certainly have a lot of clinical trials, which is the way that we move the the therapies forward in Waldenström's, which are also options. So many different options. And we're lucky enough, I think, to be able to often have a conversation with our patients about what might fit their disease and their preferences. Some patients say, absolutely not, I don't want to take a pill every day. And some people say, I don't want chemotherapy. And so we, in most cases, can really tailor our therapies to the patient's preferences and what we might expect to be best for their disease.
And Dr. Paludo, can you talk a little bit more about the fixed duration therapy versus continuous therapy, what the differences are, advantages, disadvantages?
As Dr. Sarosiek mentioned, we are very lucky now to have so many different options. A lot more options now than we had 20 years ago, Pete, when you were diagnosed. And there are different treatments, different whether they are given or administered, and we can kind of divide them into the fixed duration treatments and continuous duration treatments. What the fixed duration treatment is a treatment that has a start date and an end date. So predefined start and end dates. Those are the usual, maybe older treatments, the chemoimmunotherapy regimens like the bendamustine and rituximab, the cyclophosphamide and rituximab, and steroids. Has a date to start, there's a date to end, usually given at frequent intervals for some amount of time. And then we have the continuous treatments. Those are the newer drugs, the target therapy treatments. They have a start date, they don't have an end date predefined. Those are treatments that are continued for as long as they're working and for as long as they're not causing enough side effects that will require us to stop. That's where the BTK inhibitors come into play. Like the one you're currently taking. You started, you're going to continue that for as long as it's working, right? And as long as it's not causing enough side effects to impact your quality of life, that justifies stopping them. So they are slightly different in a way that they also interfere with quality of life or side effects. The fixed duration treatments, we usually think of them as having maybe more side effects during the time when the treatment is being given, maybe higher intensity of side effects during that time. And that's why they're often only given for a certain duration of time. The continuous therapy, on the other hand, they tend to have a lower level of side effects so that patients can continue on that treatment, every day for a long time. So different ways to look at it. I mean, the one analogy that I usually use is, if you have a Band-Aid, do you like to rip it off or do you slowly peel the Band-Aid off? So there are different ways to see it, different ways to approach that. And thankfully we have so many options so patients can choose what fits better for their goals. Shorter or fixed duration treatment versus a more continuous treatment.
Thank you. Yes. I like the Band-Aid analogy, although for me, whether you rip it off slowly or quickly, it still hurts. What always interested me was when it was time to decide on treatment, the doctor would say, well, here are your options. Which ones do you want? And I kind of sat back and said, wait a minute, I get to choose. I don't know if I'm prepared to do that. But I appreciated that, to have that option at least. And we are fortunate as WM patients to have so many different options available to us with regards to treatment. It shows the testament to the amazing research that folks like you guys are doing that have really moved the ball forward for us. And we look forward to the newer agents coming down the road also, and better treatments in the future for improved quality of life for all of us. So with that in mind, it kind of leads to the next topic, which is the possibility of clinical trials in Waldenström's and looking at the future of treatments. Kind of what's exciting to both of you at this point in time. So we'll start with Dr. Sarosiek. What are some of the studies you're most interested in, and why should patients and care partners be interested in participating in a clinical trial specifically?
Yeah, I think we're in a really exciting time right now with the number of clinical trials that we have available for Waldenström's care. I think that there are quite a few that I'm really interested in right now, but I think before I go on to the specific trials, I'll just say that in general that, clinical trials are how we move, forward in the field with Waldenström's. And I think sometimes when I bring up Waldenström's clinical trials to patients, there's an initial hesitance because of concern that maybe a patient would get a placebo and not really get treatment for their disease. I think it's important, an important thing to know or remember is that, we're certainly going to be treating our patients. And what the trials do often is just try some of the treatments in a new way. So maybe a treatment that was, effective for other types of lymphomas, and we expect it would work in Waldenström's, or maybe a combination of two effective therapies that have been used before. Instead of using one indefinitely, we use both for a shorter time, or things like that. So I think it's, patients should always be, open to asking questions about trials if they have any hesitancy, if they're worried that they're not going to get an active therapy or they're worried about side effects. They should just always, feel free to ask questions. But I think some of the trials offer an opportunity to get something new and different that might be more effective. We can't say that necessarily going into the trial, but sometimes we have some background data that really, is encouraging to us. But a couple of clinical trials we have going on right now. So a lot of patients with Waldenström's, or even just with a precursor, or they don't quite meet the criteria for Waldenström's, but they have an abnormal IgM antibody, can develop neuropathy, and specifically neuropathy that affects the lining of the nerves. So neuropathy is nerve damage, and that can happen in many ways. But often with Waldenström's, it's a type of nerve damage that affects the myelin, or the lining of the nerves. And we have a clinical trial open for really exploring that neuropathy in a different way. So treating the underlying abnormal IgM, and then following the patient's nerve damage over the course of time, and hoping to really find something that's really effective. So that's using rituximab with acalabrutinib, so an oral therapy with an infusion, and we're working on seeing if that can really protect patients' nerves. Another clinical trial we have is using a drug called loncastuximab tesirine, so a long name, but that's an antibody, or a drug that an antibody that delivers a toxin to the site where the abnormal cells are. And that's a time-limited therapy. As we mentioned, some therapies go on forever and some are time-limited. That's time-limited to 6 months. And it's for patients who have had at least 2 other types of therapy in the past. And that trial is ongoing. It's an IV therapy, as I mentioned, for 6 months total. And we have another clinical trial that's using 2 oral therapies, venetoclax and pirtobrutinib. We know both of those drugs are effective in Waldenström's on their own, but this trial is using a combination of both of those together for 2 years in hopes of deepening or getting a better control of the Waldenström's, and also in hopes of allowing patients to come off treatment after 2 years and not stay on treatment forever. So I could go on and on about all the clinical trials. There are many other clinical trials available for Waldenström's, but those are, I think, some of the more exciting ones that we're thinking about and talking about, but there are many more. And I don't know, Dr. Paludo, if you have other thoughts about clinical trials for patients with Waldenström's.
Yes, I think I completely agree. I think participating in clinical trials is very important. Participating in clinical trials helps the community of Waldenström patients to have new and other different treatment options available. And that's how we have got where we are right now compared to 20 years ago, right? All because the patients have been participating in clinical trials. But it can also help the patient themselves on the trial getting a new drug. Often the first patients to benefit from a new treatment are the ones in the clinical trials. So the ones in the ibrutinib clinical trials were the first ones to benefit from that drug, and now becomes the standard of care. And hopefully loncastuximab will become also part of the standard treatment, and those patients in the clinical trial are the first ones to benefit from that. But there are several clinical trials available for Waldenström's. There are a few that I'm very interested in seeing the results, and hope they will be available soon. There are some trials comparing different of the treatment regimens and classes that we were talking about earlier. Try to understand if one is better than another, or which situation to use one or the other. And we don't have the specific trials yet, but I'm really curious and looking forward to see what novel types of immunotherapy drugs will bring to the Waldenström's field. I mean, specifically, I've been very curious to see what we're going to find with bispecific antibodies in Waldenström's. we have seen excellent results in different lymphomas, similar to Waldenström's, and I'm hoping that we'll have clinical trials soon that will be able to investigate if those treatments are helpful in Waldenström's as well.
Thank you. Yes, with the clinical trials, I think both of you kind of touched on this, but really what it comes down to is that it is an opportunity to kind of be on the cutting edge in a sense of what treatments are out there and find something that will work well for you. But correct me if I'm wrong, but the thing that people should take away is that if you're in a position where you really need treatment, you will get treatment, whether it's from a clinical trial drug or your doctor will say, I'm sorry, you can't participate in this trial. We'll give you some kind of treatment because you really need it.
That's absolutely correct. I think no matter what, it's important for patients to understand that, if their disease needs treatment, they will get treatment for their disease. If they qualify for a trial and want to participate, they can do that through that. But we would never, advocate for a clinical trial that wouldn't provide a treatment that the patient needed. So I think that's an important thing to recognize.
And we also look for clinical trials that make sense for that patient. So the patient that needs treatment, are those new drugs in a clinical trial, do they make sense for that patient? Or do they have potential side effects that will cause more trouble, for example? Mm-hmm. We would avoid those clinical trials. So looking for a clinical trial with a treatment, but also the ones that fit and make sense for that specific patient at that moment.
So even from a patient perspective, like I mentioned that the doctor, would give me options, and the next question could always be, if they don't mention it to you, is there a clinical trial that I can participate in? Is there something out there that you're taking part in? Sometimes, depending on where you're located, though, you may have to reach out to people like at Mayo and Dana-Farber to see if there are trials available for you, and you may have to travel for that. So there is that consideration, but it is an option. So I encourage patients to always look at clinical trials and see if any of them are the right fit for you, because you help yourself and you also help other Waldenström patients in the process. So it's kind of a win-win situation. So I appreciate all your responses, and you guys, both of you have been fantastic. I don't want to say guys, both of you really are respected professionals in the Waldenström's field. And, we've been talking about watch and wait and the issues of the mental issues of dealing with that. So I'll start with Dr. Paludo first. As a final message or takeaway for any patient that's in, let's say, a watch and wait status, what's the one thing you would tell them to kind of alleviate their anxiety or issues they may have mentally in dealing with that aspect of being on watch and wait?
One of the messages I always try to convey to my patients on watch and wait is that being able to do watch and wait is actually very positive. It's an excellent situation to be where you don't need treatment. You want to kick that can down the road to only when you have symptoms. So work with your doctor, work with your hematologist, and follow up on things. Remember, you need to follow up, but being on a watch and wait is actually a very positive sign at the end of the day, despite all the anxiety that comes with that. It's an excellent position to be.
I would say that, in general, it's important to recognize that watch and wait or active monitoring is a personalized process. So it really can be adjusted as needed and will be adjusted as needed for each individual patient in terms of what to follow up on and how often to follow up. And I would encourage everyone, if possible, to find a provider or physician that they're really comfortable with, that they can go through that process with, that they feel like is really supporting them, if at all possible, and just find the person that helps you feel comfortable during that watch and wait process.
Thank you. I'd like to thank both of you for your insights and your these takeaways. They're really helpful, and the guidance that you provide to all of us. As a patient myself, I kind of always appreciate my clinician, my doctor, and the advice that he gives me. So it is important to have that good working relationship with your doctor, and also have your caregiver involved if you have someone there come to your appointments with you. So the aspect that I want to kind of take from my own personal journey is that sometimes it is okay to yell and scream and be upset and cry and whatever and let it out. Don't hold it in. But also, if you find that doesn't help, to reach out to your doctor, to your care professionals, to social workers, to whatever support network is available to you, and take advantage of that. You don't have to suffer alone. There are other people, I won't say suffering with you, but there are people there that can help you through that process. That's what they're there for, so take advantage of it. So thank you to both of you, and I really appreciate it, and I'm sure our patients will appreciate it. And we look forward to further discussions, and I also look forward to further advancements in the clinical trials and in the future of Waldenström's research. So thank you to both of you, and Stephanie, back to you.
All right, yeah, thank you so much, Pete. Before we wrap up this discussion, we'd like to spend some time on what is a very great hands-on resource at your fingertips, the LLS's Information Resource Center that features specialists who will work with people one-on-one through so many different questions. So joining me now is Jennifer Wilson. She is a senior information specialist with the LLS. So Jennifer, welcome. First, can you share the basics of how, in general, you are helping patients and care partners?
We want to make sure that when someone calls us for the first time or the 40th time, that we hear what they need, listen, and sometimes people can identify it and sometimes they can't. But we want to make sure that they have good disease information, up-to-date treatment information, and how to get support, because we know that what your needs are from day one can be very different over time.
All right, thank you for that. You know, our audience today in Waldenström's, we've got patients, care partners, people in support circles. So in particular for this group of people, what would you like to share in terms of some of the common questions and topics that come up and how you do help the folks who are approaching you?
If someone is calling and they're newly diagnosed, oftentimes they may be told, we're just going to do watch and wait. It's a chronic illness. We're just going to keep an eye on things. But to people hearing that, it can be completely overwhelming. So we prefer to use the phrase active surveillance now, because that indicates that they're keeping an eye on things. It's not just, we're going to wait and see what happens. It's a very deliberate monitoring to manage the disease. And then we look at what supports are available. And so we have what's known as a First Connection program. It's a peer-to-peer program so that someone with Waldenström's would have the opportunity to speak with someone else who perhaps has been in watch and wait, and what that felt like, and how to communicate among their friends and their family. We have an online non-Hodgkin lymphoma chat. We also have, for the caregiver, we have a caregivers chat that meets online. And we have a community, which has a designated group for Waldenström patients and family members. We have support groups locally and education programs, because knowing about the disease and the treatment options is essential. And a lot of times what we do is we just say, okay, let's figure out what you need to ask at your next appointment to ensure that when you leave that office, your top 5 questions have been answered.
All right. Thank you so much, Jennifer, for the work that you're doing to help patients and families everywhere, and including those who are dealing with Waldenström's. We will be sending links to the LLS's Information Resource Center, as well as the IWMS specific mental health support resources, all in a follow-up email. So be on the lookout for that. And we want to thank both organizations for being incredible partners. Thank you again to Pete for leading an incredible discussion today, for spending the time, but also just for your advocacy in general. It is an immeasurable impact that you have dedicated and made in this space. And on that note, also thank you to Dr. Sarosiek and Dr. Paludo for the work that you're doing, both in clinic with the people you're helping directly in Waldenström's and beyond, and also all the research that you've contributed to lifting the possibilities for everybody with Waldenström's. So thank you so much for your time today. And don't forget, for all of you, thank you for showing up, and really hope that this was helpful in some way, that there's one thing that you're walking away with feeling more confident about. We really want to hear from you. So when this discussion closes, again, a survey is going to pop up. It'll only take a few minutes to fill out, and everything that you share is really important. We read every single bit of it. And so we want to thank you in advance for at least considering sharing your thoughts on our survey. So that does it for today. Really enjoyed the discussion. Hope you did too. We hope to see you at a future program. I'm Stephanie Trong with The Patient Story. Take good care.